everyone. Good evening, good afternoon, good morning, wherever you are from. So my name is Darwin Chimba. I'm the Director of Operations for the Association of Future African Neurosurgeons, where I also happen to be the Neurosurgery and Global Neurosurgery Research Fellow. So today we are going to have another presentation by Dr. Placide NGOMA, who's going to take us through another series of our currently going on neuro-oncology course. So at this time, I'm going to call on everyone to I'm going to be calling as their names appear on my screen to introduce themselves, and then I'm going to call on the presenter to introduce himself last. I would also want to request that as the presentation is going on, please just mute your mic unless you want to ask a question, you want to say something, you can then unmute yourself. So I'm going to start with Dr. Natalie. Okay, we'll get back to Dr. Natalie. Ezekiel, you can please introduce yourself.
Yeah, good evening, everyone. I am Olaoluwa Ezekiel. I'm a second-year medical student from the University of Ibadan and a research fellow at the Association of Future African Neurosurgeons. I'm glad to be here today. Thank you.
Thank you so much, Ezekiel. It seems Dr. Natalie is back. You can please introduce yourself.
Okay. Hello, everyone. I'm Natalie Gomsi, a medical doctor resident at the University Neurosurgery at the University of Felix Houphouët-Boigny in Abidjan, Côte d'Ivoire. I'm also a founding member of AFAN, and I'm actually an assistant editor at the Annals of African Surgery.
Thank you so much.
This evening.
Thank you so much. Then Musakanya.
Good evening, everyone. My name is Musakanya Shturuka, CTA medical student from Copperbelt University, Zambia, and I'm glad to be here.
Thank you, Musakanya. We're glad to have you here. Then we have Michael.
Yeah, sorry for the music. I'm at the barbershop. My name is Michael Barrymore. I'm a fourth year medical student from Philadelphia College of Aesthetic Medicine. I'm currently a research fellow at AFAN and also at the Mayo Clinic in Jacksonville, Florida. Thank you.
Thank you so much. Then lastly, we have Dr. Chibuikem. You can please introduce yourself.
Good evening, everyone. I'm Dr. Chibuikem from Lagos, Nigeria, a research fellow at AFAN. I'm glad to be here.
Thank you so much, Dr. Chibuikem. So at this time, I'm going to hand over to the presenter. He's going to introduce himself and begin the presentation. Dr. Placide NGOMA, over to you.
Hello, everybody. I'm Placide NGOMA from Zambia. Just recently graduated from the Copperbelt University and will be hopefully starting my internship very soon. So today I'm going to be presenting on a special case, which I wouldn't want to disclose right now because it would be too early. Oh, okay. Thank you very much. Welcome to today's presentation. We are looking at case 9 in the neuro-oncology case series. My name is Placide NGOMA, as I had already introduced myself, from Zambia. So we start a case scenario without wasting a lot of time. So our case scenario goes as follows. A 45-year-old male presents with a 3-month history of left arm numbness and headaches. In the past medical history, the patient had a renal transplant. On examination, it was noted that there was decreased sensation to light touch in the distal left arm. The patient was alert and oriented. The visual fields were intact, and the patient had full strength bilaterally. So I would want us to meditate a little bit on this case scenario so that we can actually go to the next part. Okay. So just looking at the case scenario that we have, this particular case scenario, I'm sure there's already a few conditions that are coming to our minds. I would want us to brainstorm and try to make a list, a short list of some of the conditions that could make somebody present like this at our health facility. So anybody, does anybody have any ideas or anything that could actually make somebody present like this?
I'm sorry, I'm at the barber shop. So I'm just I was thinking like a spine pathology. A brain mass could be possible too, but I'm thinking something in the cervical spine perhaps.
Okay, a spine pathology. All right. Anything else?
Well, I think we can also think of a space-occupying lesion such as a tumor. Yeah, I think a tumor, which could be either malignant or benign.
Okay. Thank you very much. Yes. So the ones that we have, we've actually tried to. It would be helpful if we try to even classify them into different groups. So the list here is actually classified into neoplastic, infectious, and inflammatory or demyelinating disorders. So as you can see, these are just differentials for an intracranial mass lesion in an immunocompetent patient. Now, if we go back to the case scenario, one thing that is very important that we're going to realize is that this is a patient who had a renal transplant. In short, the importance is not the renal part, but the part that this is a transplant patient. And transplant patients are usually patients that have been on steroids. Now, what matters is how long they've been on these steroids, because the extent of the immunocompromise is actually correlated directly with how long they've been taking these steroids, or what is the time that has passed or elapsed from the time that they had that transplant. That'll give us an approximate of how long they've been on these steroids, because steroids are actually immunosuppressive. So we can actually classify this patient to be an immunocompromised patient because of the steroids that have been taken. And then another thing that we can actually note from the scenario that is very important is there's this sensory. Yes, there's a sensory disturbance. The physical exam said that there was decreased sensation to light touch in the distal left arm. So there's loss of sensation in the distal left arm. And in particular, they said light touch. You see, and even in the first part, it actually says left arm numbness and headaches. So the visual fields are intact, full strength bilaterally, and decreased sensation to light touch in the distal left arm. So this thing is pointing to a focal neurological deficit in a post-transplant patient or in an immunocompromised patient. So that's what brings us to these differentials here. So under neoplastic, we have glioma or glioblastoma, meningioma, brain metastasis, central nervous system lymphoma. Then under infectious, we've got abscess, parasitic infection like toxoplasmosis, fungal infection like aspergillosis, tuberculosis, and then inflammatory or demyelinating like MS, which is multiple sclerosis, and sarcoidosis. So at this point, I would want us to start eliminating these things, some of them one by one, because looking at the history that we've been given, I'm sure we would all agree that the history is very short. It just has 3 points. And we have a lot of these differentials, and most of the differentials, for you to be sure, you'd actually want to ask more questions. Yeah, but I think with even that short history, we'd be able to start eliminating some of these things that are on our differentials, because our list is very long here. So how do we go about, before we actually go to further investigations, just from the history, what are some of the things that we can do to narrow down this list?
Are you asking for further investigations, right?
Oh, no, not yet. We are not yet there. What I'm saying is the list is too long, but from the short history
arguments to rule out,
there are some things that you can actually sort of try to remove from this list. Okay, I'll give an example. For instance, if somebody said it was a brain metastasis, meaning it's a metastasis that's coming from another area, and the only past medical history that they've given us is post-transplant, meaning they are not giving any history of a possibility that somebody could have had a primary tumor somewhere else, systemic, that could have actually metastasized to the brain. The history is just focusing on the brain part and the fact that this is a post-transplant patient. And they do not give anything else that could actually give you a clue that somebody could have had a systemic, some other cancer in the what's this, in maybe some other organ that could have metastasized to the brain. Yeah, so I think for me, I would be comfortable to remove the brain metastasis at this point.
I suppose we could remove the meningioma too, because I mean it's more common in women, and in this situation, this is the male, and based on the history of renal transplant and phosphosteroid use, you could probably take out meningioma, at least pending like imaging.
Hey guys, we are listening to you. If you it's just like if you start talking, it will not be good. Just give your idea, and then Dr. Placide can move forward. That we no idea, I don't know, to rule out maybe glioblastoma.
Okay.
Meningioma.
I think the other thing I would also want to probably rule out infectious causes, for example, abscess, tuberculosis, and as well as parasitic infection. Specifically on tuberculosis, we can see that from the past medical history, there is really nothing much that is indicating that this patient probably had tuberculosis or could have tuberculosis, because the presentation of tuberculosis is quite classic. We may have things like night sweats, we may have things like...
Hello? All right, are we still together?
Yeah, we're together. So I don't know if I...
So yeah, we've tried to narrow down the list, and we've removed some of these things, but some of them we can actually eliminate them after doing a few investigations. So what would be the next investigation that would want to do at this point?
Yeah, you can go ahead.
So to help us narrow them down further, we order an MRI of the brain. And this is the image that we get of the MRI. Could somebody help us describe this MRI, and also probably maybe comment a little bit on how further it can help us arrive at the diagnosis? Okay, so we're going to move on. So this MRI, if you look at it, we've got three images on this, this MRI. We've got the first one that shows a single, I'm sure we can all see this single lesion, which is hyperintense, and it's homogeneous. So we've got a homogeneous hyperintense single lesion, which is on the right parietal part of the brain. So it's that's what is showing on the first one. And then on the second one is a T1. It's a T1 sequence MRI. This one is showing that this lesion is actually hypointense. And then on the third image, this is a T2. It becomes hyperintense on the T2. So let me just go on the slide that shows that, yes, brain MRI shows solitary right parietal homogeneously enhancing mass in figure A, that is hypointense on T1 flare and hyperintense on T2. So the differentials here, we have metastasis, primary brain tumor, infection, and lymphoma. Does anybody have a comment on this one?
Okay, I'm not really quite okay with the fact that you say it is a homogeneous lesion. If you watch it carefully, you will see that there's a form of, at the center, it is the first image, which is an enhancement image, T1 image. You see that there is a hypo signal at the center of the hyper intense enhancement. I don't know if you can see that.
Oh yes, I can see that there's this small part. I don't have a
And
point.
you see the same thing on a T2 image, that's image C. You see that at the center, there's a hypo-intense lesion, and around it, you can see the hyper-intense, like around it, you can see the hyper signal around. I don't know if you see it.
Yeah, I'm able to see this one.
Then a teaching for those who are at the lower classes, why do we say it is parietal? Do you see the central sulcus just in front of the lesion? It is just in the form of an omega. I don't know if everybody can see it. On the T1 image, it is better seen. That's the B, the image, the B.
It's actually more clear on the B image.
Yes. And
This
can you see
dark
the
line that actually...
That is for those medical students. When you can see that omega sign, it is usually the central sulcus. You know, usually they teach us in the lower med school that the central sulcus is dividing the frontal from the parietal lobe. So it is not usually totally dividing. So you will see that omega sign. I don't know if you can see it on the contralateral, the image contralateral to the lesion. You can clearly see the omega. And then when you project it to the side of the image, you will see that it is pushing the central sulcus forward. That the lesion is pushing the central sulcus forward.
Yes.
Okay, that was just a teaching. However, it is not really that homogeneous. There's it's some kind of heterogeneous. There's a slide, if you can see, hypointense lesion at the center. So the question I'm asking myself is the lesion around, is it not edema? Is it not is it not the edema which is causing the hypointense lesion around? That's the question I'm asking myself. Or hyperintense lesion around. What do you think, Placide?
Well,
Hello.
I would really want, I would really like some guidance on this one. Yes, but I do feel that it's the actual lesion that is here. This whole thing. Could it be that the small thing, the small thing in the middle is the actual lesion, and then the hypointense on the T1?
Exactly. It is a possibility. That's what I wanted you to see. That it is a possibility. Because there's no reason why when you say homogeneous enhancing mass, if you watch it carefully, it's not really that homogeneous. It is homogeneous. It is a homogeneous hypointense mass in the T1 image, but on the T2 and the enhancement T1 image, you can see that there's some kind of small, maybe there's some kind of small hyperintense image at the center, on the center of that enhancement. And you can see it better on T2, you see the hypointense mass.
Very, very clear. I wish I had a pointer to be able to be pointing at these ones, but the phone I'm using is not allowing. But I have noted. I've actually, it's even more clear on the T2.
Okay. I hope everyone is seeing. Please, if you're not seeing, just indicate so that it's me. Then the second thing that it's brings my curiosity about the image is there's this subcutaneous mass, which is frontal. I don't know if you see it. We can see it clearly on T1 enhancement and T1.
Yes.
You can see it, right? And then I'm asking myself, what's that?
I was also wondering what it is, despite the focus of the thing not being on that one and being on this lesion, which is on the brain. But I also tried to ask myself what that one could be.
Okay.
And why is it that it's not showing on the T2?
Oh, because if you can watch carefully, the cuts are not at the same level.
Oh.
The T2 image is a cut which is downward, which is more lower.
Yes.
Than the others.
Oh yes, that's true. The T2 is lower than the T1.
Exactly. That's why you don't really see the cut of the central sulcus on the last image compared to the others. Please, guys, can you ask questions if you have some queries or some don't understand something? Hey, Darwin, is everything understood on that image? Ezekiel, are you with us?
Yes, I'm with you.
Is everything understood on the image? Please, we don't want to frighten
No.
you guys. That's why we wanted to talk. It's just an opportunity for all of us to learn. And since most of you want to do neurosurgery or neuroradiology, it will be important that all of us have the same, or we can understand everything. For sure, we will stop and get back for those who are not understanding. That's for sure.
Thank you.
I would like to ask.
Okay.
Yes, the same part you were explaining on the homogeneous. I would like to understand what you mean by homogeneously enhancing mass. I think I'm behind on that part.
Okay. What I'll try to explain is that when you take an MRI, please, what level are you first? Let me explain the function of your level.
I'm a medical student, fifth year medical student.
Which year? Fifth year.
Fifth year, yes.
Fifth, okay, means that people have already done MRI. That's good. Okay. So when you take an MRI, the first image that you look at, we call it the anatomic image, is the T1 image. The T1 is the one that resembles mostly the anatomic or the morphologic appearance of what you find. For example, if you see on the T1 image, you will see that the white matter is white. You will see that the gray matter is gray. You will see that the bone, the bone is it is how can I say, it's calcium. It is white. It's some kind of very white because of calcium. So that's how we see. So you look first at it, then you compare. When you look at an image, please close the door. You compare both of them. You compare the right and the left hemispheres. So when you see on the left, you can see that there is something that's wrong. You can see that the circles are not okay. You can see that the circles are not really visible on one side, and on the other side, you can see it. Are you seeing it? Shitu. Let me just touch your name like that. I hope that doesn't disturb you. Can you see it? That's the B image. Are you seeing the B image?
Yes.
The B image represents the anatomic image. That's how things are presented, like it's the anatomic image. The white matter is the white thing that you see at the center. You will see the white matter being surrounded by the gray matter, which is usually the cortex. Are you seeing it?
Okay.
Then
yes,
on the right side, you have to understand that when you're reading an image, your left is the right for the image. Your left represents the right side of the person, that's of the image, and your right represents the left side. Are you visual? Are you seeing it?
Yes, I'm seeing it.
Okay, that's good. Now you will see that. Why did I say parietal? Parietal because if you watch the B image, I want you to watch it carefully. On the other side, that's on the left side, that's the left part, you can see that there's no lesion because you can see the cortex, you can see the different sulcus, and you can even see the central sulcus. Are you seeing the central sulcus? It has a form of an omega. Can you see it?
I've seen something, but
please, Placide, can you show her? Can you show her with the, I don't know. Can you do something to show her?
Able to notice the zooming in.
Okay.
Yes, yes.
You can see the omega now. Okay.
Yeah.
That's
yes,
fantastic. That's the central sulcus. Now, when you are finished to look at it like that, you see the contralateral part. Are you seeing the omega, which is being pushed by something that's a hypocineal? That's very good. So now you go to the enhancement image. The enhancement image is the A image. In the A image, how do you know that it's enhanced? You can see that there are vessels which are being colored. It means you have put a product, usually it's gadolinium, which colors the vessels. You can see it's a panthygenous or like snake-like white. Can you see it?
Yes, I can see.
It means that it has been injected. So on the B image, you can see that there's a hypocineal within the parietal, as Dr. Placide rightfully said. And then on the left, you see that on the left, that's the A image. You see that after injection, there is a part which is being enhanced. It means that when they say homogeneous, it means that the enhancement is, when they say homogeneous, it means that the enhancement, there's no, it's like homogeneous, how can I say? There's no, what would I say in English? That's when they say something is homogeneous, it's just as if you mix something and then there's no grumulous part, or when you're preparing something, I don't know, fufu, I don't know what you prepare usually. There's no grumulous part, you see. So everything is just homogeneous, like the white place or the white extension of the contrast of the enhancing product is just it's just taking place in a nice manner. That's it is beautifully represented. There's no anomalous, there's no something skipping.
Okay, so what you mean is like everything in the brain is the same. The only thing that would be different is the mass. I don't know if that's what you
the
mean.
mass is different, but when you inject the enhancing product, are you seeing on the first image, image A, are you seeing that the product is taking place, it's taking its way in the lesion, in quite, most of it is homogeneous, like.
Okay,
are
I
you
get
seeing
the
it?
point, thank you. Yes.
Then, now I was saying that I don't think it is really that homogeneous, because at the center, if you watch it carefully, you will see that there are some spaces that are not really homogeneous. You will see some black spots at the center of the enhancement. Can you see that?
Yes. Yes.
And that was my argument for heterogeneous. However, so that was just a parenthesis.
Wow.
Thank you so much for the explanation.
You're welcome.
Thank you for that explanation. I've actually learned a lot myself as well, like very, very much. I've gotten some extra detail, especially on these omega signs and them being pushed upwards. At first I didn't notice that, but now I'm able to notice that. Thank you very much for that one. Yes. So going forward, and one thing that I've also noticed is that if we go back to our scenario, the scenario said the patient had decreased sensation to light touch in the distal left arm. So this is what's this? A sensory deficit that the person has, and it's not a motor deficit because this person has got full strength bilaterally. So the fact that it's a sensory deficit, it actually agrees with this image that we have. The fact that the primary sensory cortex is actually found at the parietal side is in agreement, because if this thing was in the frontal part just above this central sulcus, just above it, probably this person would have had more of motor deficits than sensory deficits, but the primary sensory cortex is actually found right here, just next to the, just before the, the central sulcus. This someone that has got the omega sign. Thank you very much for that one. Then it is the workup. So what further investigations would we like to make in this patient? Can I have some ideas from everybody? Further investigations. We've only done one. We've just done an MRI of the brain. There's quite a lot of other different things we could do. Considering that the patient has got this special type of history, I'm sure there's more questions that one would want to ask to find out what really is going on, and probably maybe try to probe a little bit more for the sake of maybe the management of the patient, and also to get to confirm what exactly is going on. Because even though we got the MRI, it really didn't yield something very specific. We saw that there was a lesion, and we are able to correlate the lesion with the clinical picture of the patient. But what can we do now to sort of like narrow down on what is really going on in this patient?
Hello?
Hello, yes?
Yes. So I think, in the same line of imaging, we can also do imaging of the spine, that is MRI of the spine, because we can see that the spine may probably be affected as well. And then we can also do some laboratory investigations. So specifically, I really wanted to mention the MRI.
Hello, are we still together?
Yeah, I've said what I wanted to say.
Hello.
MRI of the spine. Can you get me?
Okay. Yeah. Thank you. Yes. Thank you very much. Thank you very much. I can hear you myself. Okay. So on further workup, the laboratory workup that we can do immunodeficiency workup. So by that, we can actually do an HIV, we can actually test for HIV because this, the case that we're looking at today, by the way, is primary CNS lymphomas. So we're looking at CNS lymphomas. And these are actually more common in people that are immunodeficient. I'm sure that's why even the clinical presentation tried to tell us so much that this person had a previous transplant, to tell us that probably they could have been on immunosuppressants because of the transplant. So we need to do an immunodeficiency workup, and HIV is one of the things that we will have to look at. Then we can do CSF analysis. We can do cell counts, protein, glucose, cytology, flow cytometry, and we can also do a toxoplasma antigen test. If you remember very well, in the differentials, we had toxoplasmosis. But by this time, I think toxoplasmosis would most likely have been ruled out by the imaging. Most of the times, it actually has a ring-enhancing appearance together with abscesses. Yeah, so those, but to be very sure, you actually have to do a TAT. Then PCR also has to be done. In this case, PCR, you can do for Epstein-Barr virus. There's a very, very high correlation with CNS lymphomas with Epstein-Barr virus, especially in people living with HIV. Then we can also do LDH. This is lactate dehydrogenase. It's a very it's an important prognostic marker. When it's very high, then the prognosis is bad. it actually shows hypermetabolism, and in a very aggressive tumor, it's likely going to be very high. Then we can also do the MRI of the spine, as Darwin had alluded to just previously, which is very important. This MRI of the spine is actually going to tell us whether there are actually other foci of this tumor in the spine. And also, if you remember very well, the way this situation is also presenting, there's a possibility that even just a spine lesion could actually present with a sensory deficit in one particular limb. So we wouldn't want to miss out the spine. Yes. And then also another thing that we can do is positron emission tomography to evaluate extra CNS lymphomas. So sometimes, if we don't have a primary lymphoma of the central nervous system, we could actually have the secondary one. And sometimes you actually have a metastasis in the brain instead of it being a primary coming from the brain. So you actually want to evaluate for where this could have come from. And then also, you also want to find out, has it spread? It's rare that this one will actually manage to metastasize and spread to other areas, because it's actually aggressive, and it's by the time it's done with your brain, the patient is usually gone, especially if the patient doesn't receive any treatment. Yes, but you actually also want to look in other places whether there could be metastatic foci, or maybe the primary is somewhere else and the metastatic foci is actually the one that's in the brain, in which case that wouldn't be a primary CNS lymphoma, but it would be a secondary one. Then you want to do routine preoperative labs. We'll talk about surgery later, but if you are going to do any surgery or any small procedure that involves you opening up somebody, you would have to do the common labs that are done, which include coagulation profile and the complete blood count and all the other liver function tests and kidney function tests as well. Then on the imaging part, so if you've noticed, these are just mixed up, but there's the imaging part, and then there's also just the lab part. So the MRI spine and the PET, CT are the ones that are on the imaging part. I don't know if there's any comments on this one. Anything to add?
Yes, let me add something, but this is for, okay, for those who are older, Placide like you. The MRI usually, those cuts that you have, or the sequences that you had are not usually all enough. You usually have to do more, like what we call spectroscopy MRI. What is spectroscopy? It is that the MRI tries to evaluate the molecular component of the mass or the lesion that's been seen. That usually permits us, neurosurgeon, neurologists, and you as a student, maybe if you get higher, to differentiate or have a clue on if the mass is it's a neoplastic mass, if the mass is an infection. So usually, yeah, that's something for you. You have to ask what they call a spectroscopic sequence. Yeah, I'm listening.
So that one would actually help us narrow down more to it would help us narrow down more on the differentials.
Exactly.
Thank you very much.
Amongst all those you have said, usually other sequences are better visualizes or have a better clue on the cause or the nature of the mass that you can see.
Thank you very much. Then further wake up. This is the part where we have to consult. We cannot do everything. Yes, and these consultations are very, very, very important. So we have to consult hematology. So for the hematology part, first of all, this is a lymphoma. And for the hematology part, you actually want to look for the medical management of these lymphomas, because at some point you're going to have to, if you remember very well, I'm back on the hemato-oncology. I was saying that there's a part that we had CSF analysis, and we're looking at the cells in the CSF. And we had to actually go and look at those cells. So in the analysis of these cells, you're actually going to find for this primary CNS lymphoma, you're going to find large B cells. These are the cells that are usually found in the CSF. So this is the part where the hemato-oncologist comes in, or the oncologist comes in, and they can actually advise more. And also this is the part where they can actually do more tests, like the bone marrow biopsies, and looking at different cell lines and looking at what exactly is involved. Because if we remember very well, the different blood cells, there are different blood cells that could actually be implicated in this lymphoma. And the most common in our case is the B cells. We can have T cell lymphomas, but for CNS lymphomas, it's usually the B cells that are involved. Yes, so we need to consult hemato-oncology. Then also ophthalmology is very, very important. We are going to see later on, when we go into more detail about the disease, that it's actually possible for you to have an ocular lymphoma, which it's still part of the CNS lymphomas, by the way. An ocular lymphoma is one of the presentations. So every patient that actually comes and you're suspecting of a CNS lymphoma, you actually have to do a proper ophthalmologic exam, of which you're going to have to do a slit lamp exam. Yes, and of course, the patient should be sent for a consult from ophthalmology. Yes, so these are the two important consultations that you will need to do. I don't know if there are any further additions that could be added to that.
Yeah, the further additions that is that it's very important if eventually for the oncologist to have a clue on it, because we have to note that these particular tumors are really chemo. How can I say, they are? Is it chemosensible, or they really respond well to chemotherapy? So usually there's no really big need for the surgeon at the end, because the chemotherapy is enough to treat the patient. So they are really important. It's really important to note that.
Yes, thank you very much. Okay, so let's actually look at a little bit more details of the primary CNS lymphomas. So primary CNS lymphomas, these are a high-grade non-Hodgkin's lymphoma from the B cell lineage. So these ones usually originate from the brain, leptomeninges, eyes, or spinal cord. And for these ones, you don't have to actually have evidence of systemic disease, because when you have evidence that it's somewhere else in the system, then probably the one that's in the brain is the secondary. But in this case, we're trying to focus more on the primary CNS lymphomas. So it's very important to know that you shouldn't have evidence of the systemic disease. And then these major areas that have been mentioned are very important. Can you see that the eyes are actually appearing there? So you can actually have an ocular one as well. And then also you can have one that's from the leptomeninges. So unlike the image that we had on the MRI, that one you could actually see that it was coming from the brain tissue proper itself. but you can actually have one that's coming from the leptomeninges, which would have presented in a more extraaxial view on that MRI. That one seemed to be, that one was actually intraaxial. Yes, and then let's look at the epidemiology of these primary CNS lymphomas. So 4% of newly diagnosed primary CNS tumors are actually primary CNS lymphomas. So they are not very, very common, but they are very important for us to know. Now, this actually incidence actually increases even more with with the state of being immunocompromised. So when you look at for some of the countries that have got high rates of HIV, this actually even increases more, because in immunocompromised people, especially people living with HIV and AIDS, this is the most common CNS tumor that they will have. But in the general population, that's not the case. So the median age at diagnosis is the 5th decade, which is just between, it's about 50 years, somewhere 45 to 65 years. But in our setting, in people that are living with HIV and AIDS and markedly immunocompromised, the median age at diagnosis is actually 35 years of age. So it's a drastic reduction from 50 years to 35 years. So in immunocompetent individuals, the ratio of men to women is 2 to 1, but in immunocompromised individuals, it's actually almost the same. That's the literature that I found. Then also, the World Health Organization tries to classify, it actually classified them in 2016. So it classified the primary CNS lymphomas into 5 groups, of which there's a lot of overlap. So if we can see, for instance, there's diffuse large B-cell lymphomas of the CNS, of which I would want to say, we are going to actually even note this later on, that most of them, 90% of the cases of CNS lymphomas, primary CNS lymphomas, are actually diffuse large B-cell lymphomas. But anyway, you can, and if it's in HIV and AIDS patients, the percentage actually even goes higher. It actually goes close to 100. So we can actually classify them into this. The first one that I mentioned, diffuse large B-cell lymphomas of the CNS. Then the second group is immunodeficiency-associated CNS lymphomas. If you can notice the things that are falling under here, these are all situations that actually put somebody in an immunodeficient state. So there's AIDS-related diffuse large B-cell lymphoma. Now notice how the word diffuse large B-cell lymphoma comes back. And then there's also Epstein-Barr virus positive diffuse large B-cell lymphoma. Then there's lymphomatoid granulomatosis. Then there's post-transplant lymphoproliferative disorder. Now, notice how the word large B-cell, because the Epstein-Barr part, there's large B-cell, then there's also large B-cell. But then the first case is when the patient is immunocompetent. And then the second part is when they're immunosuppressed. Then there's also intravascular large B-cell lymphoma and the other types of B-cell lymphomas. So in our case, I would think ours falls under the immunodeficiency-associated CNS lymphomas. Then let's look at the pathophysiology a little bit. So just a description, I tried to sort of give a description just previously. CNS lymphomas are malignant lymphomas heavily associated with immunocompromised hosts, including HIV and AIDS, organ transplant like our patient, for instance, and inherited immunodeficiencies. Like some of them are combined variable immunodeficiencies, Wiskott-Aldrich syndrome, and ataxia telangiectasia. These are just inherited immunodeficiencies or primary immunodeficiencies. However, primary CNS lymphomas can also occur in immunocompetent patients. Ours, I wouldn't call our patient immunocompetent. Yes. So Epstein-Barr virus infection has been associated with CNS lymphomas in both immunocompromised and immunocompetent, but the thing is, for EBV, in immunocompromised people, especially in people with HIV and AIDS, the rates of EBV positive cases in people with primary CNS lymphomas is close to 100%. So there's that correlation actually between EBV and what's this, and people with AIDS having primary CNS lymphomas. Autoimmune disease such as rheumatoid arthritis also predispose greatly. Now, here is something that I found very, very tricky to understand. So the question that these people have been trying to ask themselves is, there's been a lot of research going on, and they've been trying to find out, really, do they arise from transformed B cells originating outside the brain, or do they come from inside the brain? That one is not very, very clear. Because the thing is that there are lymphatic vessels that are present in the duravenous sinuses, but the brain parenchyma itself, it lacks classical lymphatics. So now the question is, where do these lymphomas really come from? Because even in the brain tissue itself, there are few lymphocytes in there. Yeah, so, but why do these lymphomas arise in the brain, despite the fact that there are few lymphocytes in the brain? So what they've actually found out is these cells, these B cells that are actually found in these tumors are highly selective to brain tissue. They've got adhesion molecules that make them more adherent to brain tissue. So there's neurotropism. So there are specific surface adhesion molecules that they use to actually stick to neural tissue. So that's one of the factors that they've actually found out that predispose the formation of these tumors in the brain. Yeah. Then also some of the things that have actually been found out is that immunoglobulin variable heavy gene analysis suggests the origin from B cells. So they've actually been able to say that, okay, these are coming from B cells. Remember that the B cells are the ones that are in charge of secreting the immunoglobulins. So they're able to tell that these are coming from, these lymphomas are coming from the B cells. And they're able to tell that, okay, this clone of B cells, there's this clone of B cells that has actually increased in number than normal. And there's this particular type of immunoglobulin that is all over the place, and it's just one type. The IgGs are supposed to be variable, but if you find that it's just one specific type, then you could actually conclude that there's probably one lineage of B cells that has undergone clonal expansion, and not necessarily clonal expansion in an inflammatory way, but in a more malignant way, and these immunoglobulins are being produced. And if you remember very well, in our investigations, there was a part actually for looking at the levels of IgGs. Yes, and then another part, so we're going to look at the gross pathology of these ones. So if you can look at the images that we have, we've got 3 pictures here. So usually most of the times, these lymphomas present as a single lesion. but they can actually be multiple lesions, especially in people with immunodeficiencies. You can actually have multiple lesions. So the description that they give these ones on gross, the pathologists call this a fish flesh consistency. So if you've actually eaten fresh fish before, you'd actually see that these lesions are looking like the fish, the inside of the steak of a fish. I don't know if you call it steak, fish meat. Yes, so they actually look that pinkish like that inside. And then so these are a little bit different from astrocytomas, because lymphomas tend to be relatively well demarcated rather than diffusely infiltrating. Now, this is a little bit confusing because on gross imaging, I wish I had a pointer. On gross imaging, especially when you look at the first image here, let me go back to the, is everybody following?
Yes, we're following.
When we look at the first image, if you can see there's the first arrow, the second arrow, if you can look at them, so these are the lateral ventricles just above the lateral ventricles. You're able to see that there's this part that looks like fish flesh, and it's well demarcated. It doesn't seem to be getting inside the other tissues too much. Yeah, but when you look at, for most of the literature I've come across on MRI, like the one that we had, most of the literature said that they have poorly demarcated borders. So it's like the borders fade in, and like having a border that is sharp, the border sort of like just fades in like that. And then if you look at the second one here, the second one actually has a necrotic center here, and yeah. So in most of the cases, most of the lymphomas actually do not undergo necrosis, but the very aggressive ones actually undergo necrosis at the center, especially in people with HIV and AIDS, in immunocompromised people, let me just say, because of the aggressiveness of the tumor, it sort of tends to overgrow the capacity of vascularization, and it just starts dying in the middle because of reduced nutrition. There's no nutrients rich. It's just it's outgrowing its capacity to vascularize and supply itself with the nutrients. Yes, and then intratumoral hemorrhages are also rare, but they are quite common in immunocompromised patients. Then on histopathology, this is I don't know if it's clear, but this one looks like a hematoxylin and eosin stained slide. So I think, yes, let's look at it. So these tumors are actually described to be highly cellular. There's so many cells going on there. There are a lot of cells. When you just look at it, there's so much of that purple going on. There's a lot of cells. There's so much going on this picture. So if you can notice, there are these large atypical cells with I'm failing to zoom in properly. What has it done now? Okay, pardon my technology. Okay, I think we're there. Okay, yes, there are atypical cells, and all those properties of malignant transformation that happen are actually visible. It's just that it's hard for me to zoom in, but you'd actually see that there's these cells with very large nuclei going on. So the nuclear cytoplasmic ratio is increased. Yes. And one thing that you can notice here, very much noticeable, is how they are clustering around the blood vessels. Are you able to see the blood vessels? There are blood vessels. I don't know if anybody can see the blood vessels. Okay, the blood vessels, if you can see, there are cells that are looking purple and there are cells that are looking red, forming these shapes in the middle. The ones that look red are forming, okay, here there's a blood, this one is a blood vessel in the top. Can you see in your top left corner, that one there is a vessel, and then in that one there that I'm right is actually a vessel. That one you can just that vessel has been cut in a longitudinal section, but if you can notice, it's out now. These cells are actually clustering. They've got this specific affinity towards the vessels, so they are coming closer to the vessels. So this is one thing that has been noticed about these primary CNS lymphomas. You'd actually find that they've got affinity to be, the cells have got an affinity towards the blood vessels. Yes, and then one thing that is very, very important for us to know when we're looking at this picture is that this picture can be changed very quickly with corticosteroids. This tumor responds very fast to corticosteroids, though that's not the mainstay of treatment. I'll explain a little bit later, but if you had to take this for histopathology and you started giving a person corticosteroids, there's a high chance that the histopathology slide is going to come out negative. So what they say is that when a patient has, when you're suspecting this primary CNS lymphoma, stop steroids. Stop so that you give time for the histopathological analysis to be done, for the biopsy to be taken. Because if you continue with the steroids, you're going to continue yielding negative, you're going to continue yielding negative histopathologies, which wouldn't be a good thing because you will mismanage the patient. And remember, our patient is a patient who had a renal transplant, so they most likely were on steroids. So for the sake of this, you'd have to want to hold off the steroids. There are special cases where you continue giving steroids. Say, for instance, there's a lot of edema going on, there's raised intracranial pressure, and there's a lot of inflammation going on in the brain, and you want to reduce that edema. So there's room for steroids there just to reduce the intracranial pressure and bring it back to normal. Of course, you'd have to also be giving those other diuretics. Yes, but at least at that point, there's room for steroids. So let's just move on to the predisposing factors. So the predisposing factors, the main ones are these ones. So there's immunodeficiency, which we've been singing the whole time. And then there's also autoimmune disease, of which I mentioned some autoimmune conditions can actually predispose. And then following organ transplant, our special case is actually after organ transplant. And then following demyelinating disorders, this is rare, but certain conditions like multiple sclerosis can actually predispose to this condition. Clinical presentation, although we've had a clinical case, but our clinical case was not really, it didn't cover a lot of things. It just gave us a neurological deficit. But there are many ways that these people could present. So the most important, which is 70% of the times will be there, is focal neurological deficit. So these ones can include things like, for instance, if you saw that our patient had a sensory deficit, some people can actually have CNS cranial nerve pulses, and they can also have other problems like ataxia, CNS lesions on different parts of the brain, aphasia. Depends on where the lesion is, the part that it's affecting. There's going to be a problem. If it was in the primary motor cortex, for instance, it could even start causing seizures, and you would actually sometimes even paralysis, paresis, and all those other things. So then about in 43% of the cases, there's you can observe neuropsychiatric symptoms, And these are things like depression, confusion, yes. And then also 33% of them show signs of increased intracranial pressure. Of course, we talked about a space-occupying lesion and the mass effect that it has in the brain. So intracranial pressure increases in about 33%, and they'll show all those signs. Yes, and then some have seizures. We've already talked about that, and the ocular symptoms in 4%. And remember that we have to. There was a part where we mentioned you have to actually see an ophthalmologist. So sometimes, you know, they get blood vision, diminished visual acuity, and just painful eyes. Sometimes they can have visual loss as well. And if at all, it's coming from the meninges, because remember we talked about involvement of the meninges at some point. They can have all those signs of meningeal involvement, but it's quite rare. It's rare that will be the case. Okay. Then also there's a special case. There's a special situation condition that happens in these ones. It's actually called neurolymphomatosis. It's one of the syndromes of primary CNS lymphoma. So now, remember, primary CNS lymphoma is in the CNS, but in neurolymphomatosis, it actually involves the CNS and also sometimes involves the nerves, the peripheral nerves. In this case, it's called neurolymphomatosis, and it actually presents with different pain syndromes. Migratory pain syndrome may actually emerge. Yes, so this is a special case where they're actually involving the peripheral nerves, but classically, it's supposed to be confined to the central nervous system. So I don't know if anybody has questions on that, what we've just discussed before we go on the treatment.
I don't think there are any questions. You can go ahead.
Okay, thank you very much. So we're going to go to the treatment. So, of course, before you even just go to the treatment, the whole management thing, this one you'd have already canceled the patient, you'd have already made them feel, you know, at least comfortable, because this is a cancer that we're actually talking about. Yes, so you'd have already done all those preliminaries. So we're going to go to the treatment options that we have. So basically we have three main treatment options. We've got surgery, medications, and radiation. So surgery, let's start with surgery. The reason we are starting with surgery, it's quite controversial to start with surgery. Like, people would be like, why would you go straight to surgery before you talk about the medication? But the reason why we are on surgery here is because of the biopsy. So the biopsy itself is not a treatment, but an investigation. And it's the only reason why we are talking about surgery here. So the biopsy that you do is a stereotactic biopsy. And it's basically the procedure of choice to establish tissue diagnosis, especially if CSF cytology fails. Now remember, we did a CSF cytology under the investigations. If that fails and does not yield anything, you can actually go ahead and do a stereotactic biopsy, but you're not going to start a patient on chemo without actually being sure of what type of a cancer that you're dealing with. So this one, and then surgery is contraindicated. So surgery has been linked to poor prognosis in these cancers. So it's very, very much contraindicated. And that's why we won't even go into resection. Resection is not even discussed these days. They used to do it back in the days, but due to more research, they figured out that it has actually been linked to worse complications and also poorer prognosis. We talk about medications. So firstly, we talk about steroids. So under steroids, steroids can be given in stable patients. They should not be administered before biopsy because they interfere with histologic analysis. But in a patient who's unstable, like, as I said, when intracranial pressure is very high, steroids may be given as we are awaiting surgical decompression. So there are some times when the intracranial pressure is just too high that you can actually, you will have to do a surgical decompression, especially if the problem is arising from the growth of the tumor. The tumor is actually growing very much. There are many factors that could cause high intracranial pressure. So the tissue factor, we're talking about the tissue factor and the growth of that tissue. In that case, they could be edema, and you give steroids, anti-inflammatory, reduce on the edema, and yeah. And then also chemotherapy. Now, when we talk about chemotherapy, there are many regimens that have been discussed for this primary CNS lymphoma. The main one that is recommended is methotrexate. Now, not just the normal dose of methotrexate, they recommend high dose methotrexate. So this is the first line for CNS lymphomas, high dose methotrexate. Now, high dose methotrexate sometimes is used together with other drugs, but this is the main drug. So there's a lot of other different regimens that, like they would use regimens like the CHOP regimen back, but it's not as effective as high dose methotrexate. But you will notice that it responds very well. This lymphoma responds very well to high dose methotrexate. It gives the best chance of remission. Then the treatment option number 3 is radiation. If you remember very well, I made a point when we were talking about the gross, that this under gross, I said that it looks well demarcated, but I went on to say that under histology and under radiology, the borders are not well circumscribed. So this has got a tendency to infiltrate. It will look like it's on one spot, yes, but it has actually infiltrated throughout. So even when you're doing the radiology, you do not target the lesion. No, it's actually more advisable to do whole brain radiation, where you radiate the whole brain. Now, of course, the consequences and the problems that would result from that are actually even more. But it's the type of radiation that is actually preferred and has got better results. And what they do is they combine high dose methotrexate together with whole brain radiation. But according to the protocols that I looked at, you start with the high dose methotrexate before you even think about the whole brain radiation. And when they come back for the second time, maybe when it has actually relapsed, then you can do the combination of the two, whole brain radiation and together with high dose methotrexate. It gives a better prognosis if you combine the two than just giving one alone. But the problem with this, and the reason why it should actually, why people don't rush into it, are the problems that actually come with this. Methotrexate itself is a very powerful drug, which actually has a lot of side effects, and the radiation itself has a lot of effects as well, which we are going to look at. So let's look at the surgical technique that we actually discussed for the sake of the surgery part, because of the whole neurosurgery thing. So the surgery part, as we said, the most important thing under the surgery part is the stereotactic biopsy. Yeah, it has caught up. It's on stereotactic biopsy. So the surgery part is stereotactic biopsy. Now, there are two main systems that are being used. There's frame-based and frameless systems. But these days now, they are doing more of the frameless system. So I don't, if you can look to the left, there's this one actually has a frame. I can't point at it, but let me just zoom in. This whole set has a frame. So it's a frame-based system. And then if you can look to the right, there's no frame. You'd wonder what is guiding it. How come, wouldn't you actually end up biopsying other structures and missing? But these ones are actually done with the aid of neuron. So it's that we're seeing here, so we can see the screen. It's actually able to pinpoint in real time where the biopsy needle is going. So this one is frameless system with aided neural navigation. So that's more of what they're doing now. They're moving towards the frameless system with neural navigation. So let's talk about the complications. For the sake of time, I'll just try to rush through that. So when you look at the complications, we can have complications due to the surgical part, which is the stereotactic biopsy. We can also have complications due to chemotherapy and radiotherapy. So for the stereotactic biopsy or surgery, you know, when you're talking about such things, hemorrhage is one thing that actually comes to your mind, especially in the acute phase. There's most likely going to be a lot of hemorrhage. So these ones include intratumoral hemorrhage, intraparenchymal hemorrhage, and you can also bleed into the ventricles. So these are some of the things that happen. So before you actually even do this stereotactic biopsy, you should choose a pathway that you're going to use to access your tumor, which tries to avoid parts that bleed easily. Like the sulci, they are highly vascularized because of the meninges that pass through them that also have a lot of vessels in them. And then also the ventricles, you do not want to hemorrhage into the ventricles, and just other eloquent brain regions. If bleeding occurs from the biopsy site, you can leave a cannula in sight so that the blood can actually flow out. Remember, the cranium is a closed space, so anything increases. The Monro-Kelly hypothesis, one thing increases in high intracranial pressure, you're actually affecting everything else. So we can't expand. So avoid things like bleeding. It's going to cause a lot of raise in intracranial pressure. So you're leaving this thing inside. And after you do the biopsy, order a CT just to be safe so that you make sure that there's no hemorrhage that's going on. We're going to talk about the complication of chemoradiation. So for the radiation, you're trying to avoid, remember we are radiating the whole brain. So you're trying to avoid things like leukoencephalopathy, and also the methotrexate itself is actually toxic. Most of these anti-cancer agents are actually toxic because they do not only affect the cells that you're fighting, they also affect the other cells. So there's a component of neurotoxicity that is found there. Now, if there's a diagram here, so it talks about methotrexate and where methotrexate acts. So methotrexate is an antifolate. It acts in the folic pathway. And so what they do to actually antagonize the effects of methotrexate is to give folinic acid. Folinic acid is also called leucovorin. So if you're giving methotrexate, it's very, very wise to give folinic acid as well to avoid the extreme effects of methotrexate. So you're trying to just reduce on the effects of methotrexate. This is also called a leucovorin rescue. So when you hear leucovorin rescue, you're giving folinic acid when you're also giving methotrexate so that you just try to reduce those effects, because there's quite a lot of effects. You can have all sorts of cytopenias, pancytopenias due to these what's the methotrexate. And remember, this one is actually going systemic. So this pretty much summarizes my presentation today. So I will end here and ask if you've got questions, corrections.
Hello, good evening.
Good evening.
Yes, Dr. Mapo here, calling from Zambia.
Oh, thank you very much.
Yeah, congratulations for the beautiful presentation.
Thank you.
Yeah, so I just have one question on the imaging.
Yes.
Yes, I just want to find out after the biopsy. I heard you mentioning that we need to do another MRI just to make sure that there's no hemorrhage inside. So my question is, what is the interval in between two MRIs and its complications?
Can I get help from our senior doctors? Kindly come to the rescue, please.
I don't know if I got the question clearly. I don't know if you can come again.
Yes, I think I just wanted to find out the time frame when you do the first MRI just to do your diagnosis, and the time frame after biopsy. When are you supposed to do another MRI, and what are the complications when you do it, you know, in a not taking into account the proper time frame in between two MRIs?
Oh, okay. I don't know if Dr. Natalie wants to take on that. Please, you can go ahead.
Okay, but it's a good question, Dr. Nwepu. Actually, after biopsy, if no complications within the next day, what we usually go for is for a CT scan, either the same day or the next day after the biopsy. But then we can do an MRI maybe 48 hours later. That's what we usually do here. What I've watched once done, sometimes done. Now, however, I think the focus here is for us to understand that the biopsy will help us to give the rightful diagnosis of the lymphoma, which will be rightly, as Dr. Placide said, be treated either by chemotherapy, which responds well to chemotherapy, and secondly to radiotherapy. I think that's what we have to retain on lymphomas.
Thank you.
Hope I've answered you, Dr. Nwepu. Hello?
Yes, Dr. Natalie.
Have I tried to answer the question?
Yes. But anyway, I think what I wanted exactly is to know, because it's okay, you know, the approach, I really love that. Instead of going to another MRI, just go to a CT scan. But what I want to scientifically understand, is it okay if after a biopsy, immediately, maybe after 48 hours, I can go for another MRI? What are the complications involved? That was what I wanted to have some more clarification for those that are, you know, in attendance.
Normally, there's no complication going for another MRI, because MRI is not irradiating. It's not it does not use how do you call it, like ionizing radiations. So there are not usually complications used doing for you to do an MRI after the biopsy. An MRI is usually done. It's the best exam to evaluate post-operatory actions usually. So I don't think, or I've never read about complications due to MRI, except if the patient has magnetic on himself, magnetic substances like maybe iron or other magnetic instruments. But apart from that, if the patient does not have any magnetic instrument on himself, there's usually no complication.
All right, thank you so very much, Dr. Nathan. Thank you.
You're welcome.
Greetings, everyone.
Hello.
Yeah, Dr. Placide, first of all, thank you very much for the presentation. It was really great. I really enjoyed it. I have one question. It's not only for the doctor, like to all the panelists. Dr. Placide mentioned about the whole brain radiotherapy and methotrexate, and all of those have could give serious complications to the patient. But now I wanted to know, now how do you do to weigh the benefits of receiving those treatments and the adverse effects of those therapies? How do you do to weigh, okay, that maybe by giving those treatments, instead maybe the patient can instead be instead the prognosis can instead be low compared to maybe not giving the patient a treatment at all?
Okay, Benjo, that's a good question. That's a good question. But it's just like, what will I give you as an example? All treatment, have complications, and for drugs that are used, drugs or methodologies that are used to treat cancer are usually all invasive for now. It is now that we are progressing with molecular treatments, immunotherapy, and with much molecular treatments or target treatments, both with radiotherapy, which you've heard about, I think, stereotaxy, and with chemotherapy, I think you've heard about immunotherapy, that we reduce the side effects of these dangerous drugs, because these drugs, to be sincere, are dangerous. Radiation is dangerous. However, you need them for your treatment. Complications may occur with these treatments. For example, radiotherapy, one of the most complications of radiotherapy of the head, of the brain, is edema. All these therapy have side effects, but it is not because you have side effects that you won't treat the patient, because the tumor alone, if it continues growing, you may need either a more invasive treatment, surgical treatment, or it reduces the chances of the patient. So what should you do? Shouldn't you try something at least? If it works, that's why the workup is, that was a very good presentation that Dr. Placide did. The workup is supposed to be a collegial workup. It involves people from different specialties. Apart from the neurosurgeon, usually the neurosurgeon has really a little role with the biopsy. You have to work with the hematologist, work with the oncologist, work with people from other specialties so that they can do a general workup on the patient before giving or starting treatment. That's the particularity or the peculiarity with oncology usually. They can't work alone. You cannot work alone if you're a neurosurgeon, you can't. But should you not do anything because there's a risk? That's the question that you have to ask yourself. I don't know if I try to give you an orientation.
Yes, you did, Dr. Natalie. Thank you very much.
However, Placide, I enjoyed your presentation. Sorry, I couldn't be there all the time. I have to leave all of you, but I think what medical students should keep about these presentations is how the different manifestations or the different signs and symptoms of patients can orientate where or draw you where a particular diagnosis, and how to construct the way you can work up on your diagnosis to be clearer, to have a better management. So what I would have expected from med students to understand from this presentation, it was really very meticulous. If you can go on the clinical presentation, Dr. Placide, you will see that this patient has a decreased sensation to light touch in the distal arm. And you notice that your patient had a left arm numbness, that decreased sensation to light touch. The patient had a lesion which was in the parietal zone, and the parietal zone is the lobe, the parietal lobe is the lobe of sensitivity, or sensitivity, that's That's the sensitive lobe, touch, how you understand yourself. Somebody touch you on the part of your body, how you feel it. For kinesthesia, for baresthesia is pressure that somebody does pressure, and you can feel the pressure if somebody is pressing your arm or something. Even the sense of your body within space. So it was a very important, because from the exam you can think, or you can have a clue on where can be the lesion without even saying it. You have a patient with headaches. You have a patient who has a 3 months history. Time is very important, because a lesion which starts, or signs and symptoms which start in an acute manner is different from signs and symptoms. Diagnosis for signs and symptoms which start in a brutal manner, and those starting with time, as for like 3 months, as they said, the diagnosis orientation is usually different. And that's why when you see a patient who has an acute onset of signs and of neurological signs and symptoms, that's how you think, it may be a vascular. It can be vascular. That's the first thing that you think. It can be vascular. But when they say it has been 3 months, the onset of the signs of the signs and symptoms has been 3 months, has been progressive. The first thing that you think about is something, a mass, call it a mass inside the head. A mass inside the head, which can be rightfully compartmented everything. He said it can be neoplasic, it can be infectious, it can be inflammatory. It was well organized. That's how you should think when you're a med student. You have to divide what was the onset, or how was the onset of the signs and symptoms. You already have how you die. That's how you rule out vascular. You saw that on the different diagnosis. Vascular was not even evoked. They didn't even talk about vascular lesions, because the onset was progressive. Then they went, secondly, they said renal transplant. That was wonderful. Placide rightfully explained it. People who has been transplanted, usually they are under immunosuppressants. And immunosuppressant, meaning if you're under immunosuppressant, this means that you are not immunocompetent, you are immunodepressed. So what can happen to an immunodepressed patient? That's how you should think. They are really likely to be infected, as they have infections, repeated infections. They are likely to develop tumors. And what tumors are they likely to develop? Usually, the first that we think is lymphomas. Lymphomas is related to the immune system. So when you have a reduced immune system, maybe the body will reflect on how to protect yourself better than you saw. These are usually tumors that you found in immunodepressed people. Then you go further and then you look at the exam. It was really, that's how you should think when you are seeing a patient. That's why you say when you examine a patient, the history of the onset of the clinical signs, you usually can imagine already the diagnosis. So it's very important for a medical student to have a good history, a chronological way of writing the history of the pathology of the signs and symptoms that the patient is having. Then you progress. The next thing is how I have thought of infection, I have thought of neoplasia, I've thought of inflammatory. How do I rule out this diagnosis? The best thing is, one, you think, if the person is having, how do I rule out this diagnosis? How do I find where the patient is having a problem? One, you do an MRI. You do an MRI all of you should know that MRI have different sequences. The main sequences that you want to see on an MRI is T1 sequence, T1 weighted imaging, T2 weighted imaging, FLAIR imaging. Those three are very important. And then you add enhancement imaging, and then there are others. After you've watched that, you have to rule out, okay, there's something or there's nothing. If there's something, what should I do? What is it eventually? You have to read on, this is for maybe people who are ahead. You have to read on the different appearance of different pathologies within how the image, the MRI images of different pathologies can appear. And this was really not typical because there are really differential diagnoses in front of the lesions that we saw, but it's usually typical of lymphomas. I know that the differential diagnosis there could have been exactly a metastasis, but it could have also been a glioma. It's just that it was not, the renal transplantation was an unfavored argument for gliomas, but it can also be, it could have also been a glioma. And then that's how you proceed. Don't ever forget, dear medicine, don't ever forget to work with other people from other specialties. This is a good case of how to work with in a collegial manner. So I am very impressed by your levels, and I say big up to AFAN for all of you. So thank you.
Thank you very much. Wow.
All right. Are there any more questions or any other clarifications? Any other clarifications?